Greetings everyone, I'm Dabigatran.
And I'm Rivaroxaban. Today, you will be getting to know more about us as anticoagulants. Are you ready? Let's go!
My generic name is Dabigatran. People also call me by my trade names such as Produxa, Pradox, and Prazoxa. And this is my chemical name. It's pretty long, so just call me Dabigatran. Rivaroxaban and I belong to the therapeutic class called Anticoagulants, also known as blood thinners. My pharmacology class is direct thrombin inhibitors. I belong to the pregnancy category C since there are no adequate and well-controlled studies about me in pregnant women. For my mechanism of action, I am hydrolyzed to the active dabigatran by an esterase which induces hydrolysis. My glucuronidated metabolites and I all share equal pharmacological activity. We inhibit thrombin, a serine protease. This inhibition prevents the thrombin-mediated conversion of fibrinogen to fibrin, an early step in the coagulation cascade. With reduced conversion of fibrinogen to fibrin, clotting time increases. I am 3 to 7% bioavailable when taken orally, reaching a maximum concentration 1 hour after administration in fasted subjects. When taken with a meal that is high in fat, the time to maximum concentration increases to 2 hours, though this does not affect dosing. Dabigatran ethoxylates bioavailability increases to 75% when taken without the capsule shell, and so patients should not chew or crush the capsules. My volume of distribution is 50 to 70 liters and I am 35% bounded to plasma proteins. I am metabolized by esterases, microsomal carboxylesterases, and uridine 5-diphosphoglucuronosyl transferases. I undergo hydrolysis to create the active dabigatran, which is then glucuronidated. For my excretion, I am eliminated primarily in the urine. My renal clearance is 80% of total clearance after intravenous administration. After oral administration of radio-labeled dabigatran, 7% of radioactivity is recovered in urine and 86% in feces. My indications would be, first, to reduce risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. Next, to treat deep vein thrombosis and pulmonary embolism in patients with creatinine clearance greater than 30 ml per minute who have been treated with a parenteral anticoagulant for 5 to 10 days. To reduce risk of recurrence of deep vein thrombosis and pulmonary embolism in patients with creatinine clearance greater than 30 ml per minute who have been previously treated. Lastly, prophylaxis of deep vein thrombosis and pulmonary embolism after hip replacement surgery. For my contraindications, consider potential risk of epidural or spinal hematoma versus potential benefit in patients scheduled for spinal procedures such as spinal or epidural anesthesia or spinal puncture. Hematomas may result in long-term or permanent paralysis. Increased risk may occur with use of indwelling epidural catheters and concomitant use of drugs that affect hematosis. I am also contraindicated in patients that are hypersensitive to drug and in those with active pathologic bleeding, as well as patients with mechanical prostatic valves. Use in patients with atrial fibrillation in the setting of other forms of valvular heart disease, including the presence of bioprosthetic heart valve, is not recommended. For my side and adverse effects, in the GI tract, I may cause dyspepsia, abdominal pain, abdominal discomfort, gastritis-like symptoms, GERD, esophagitis, erosive gastritis, gastric hemorrhage, hemorrhagic erosive gastritis, GI ulcer, diarrhea, nausea, and GI bleeding. For hematologic, life-threatening bleeding, major bleeding, or any bleeding. For the nursing responsibilities, it would be monitor patients for signs of bleeding. If bleeding occurs, stop drug, investigate cause, and provide supportive measures. Monitor electroconvulsive therapy or a physical performance test to assess treatment effectiveness. Monitor patient with neurologic impairment, treat impairment urgently, and discontinue administration of Dabigatran 1 to 2 days before invasive or surgical procedures in patients with creatinine clearance of 50 ml per minute or more, and 3 to 5 days in patients with creatinine clearance of less than 50 ml per minute. For patient teaching, advise patient to keep drug in original bottle to protect from moisture, to remove only one capsule from the open bottle at the time of use, to tightly close the bottle immediately after removing drug, and not to put drug in pill boxes or pill organizers. Tell the patient that drug may be taken without regard to food, and advise the patient to take the Dabigatran at approximately the same times each day. A missed dose may be skipped only if it can be taken at least 6 hours before the next scheduled dose. Teach patient to swallow the capsule whole with a full glass of water and not to open, crush, or chew it. Caution patient to take drug as prescribed and not to stop or change dosage without first consulting prescriber. Advise patient to tell all healthcare providers about taking drug, and tell patients to inform prescriber about use of other drugs including over-the-counters, vitamins, and herbs. Warn patient that bruising may occur more easily and bleeding may last longer during therapy. Instruct patient to report bleeding when brushing teeth or shaving, blood in vomit, urine or stool, heavier menstrual bleeding, or nosebleeds. Tell patient regular blood tests to monitor drugs effects will be needed. Instruct patient to inform healthcare provider of scheduled invasive procedures, including dental work. Drug may need to be stopped temporarily. Now that you've come to know me, it's time for you to meet Rivaroxaban.
Hi, I'm Rivaroxaban. I am also known by my brand name Saralto. My chemical name is this long, so just call me Rivaroxaban. As what Dabigatran mentioned earlier, we belong to the same therapeutic class, which is anticoagulants, but I belong to a different pharmacologic class, which is factor XA inhibitors. I am listed by the US FDA in the pregnancy category C, which states animal reproduction studies have shown an adverse effect on the fetus, and there are no adequate and well-controlled studies in humans, but potential benefits may warrant use of the drug in pregnant women despite potential risks. I competitively inhibit free and clot-bound factor XA. Factor XA is needed to activate prothrombin to thrombin. Thrombin is a serine protease that is required to activate fibrinogen to fibrin, which is the loose meshwork that completes the clotting process. Since one molecule of factor XA can generate more than 1,000 molecules of thrombin, selective inhibitors of factor XA are profoundly useful in terminating the amplification of thrombin generation. The action of Rivaroxaban is irreversible. When taken orally, IM rapidly absorbed and reaches peak plasma concentration in 2 to 4 hours. The bioavailability of the 10 mg dose is greater than 80%. However, the 15 to 20 mg dose have a lower bioavailability if taken in the fasted state, and consequently should be taken with food. My steady-state volume of distribution is 50 liters, and plasma protein binding is about 92% to 95%. Approximately 2/3 of the dose is metabolized. It is metabolized by CYP3A4, CYP3A5, CYP2J2, and CYP-independent mechanisms. For excretion, approximately 2/3 of Rivaroxaban is excreted into urine. The remaining third of the administered dose is excreted via feces, in which 7% is in the form of unchanged drug and 21% as inactive metabolites. My indications are prophylaxis of deep vein thrombosis that may lead to pulmonary embolism in patients undergoing knee or hip replacement surgery, treatment of DVT or PE to decrease risk of recurrent DVT or PE after initial 6 months of treatment, and stroke and systemic embolism risk reduction in patients with non-valvular atrial fibrillation. I am contraindicated in patients hypersensitive to drug and those with active major bleeding. Use isn't recommended in patients with prostatic Keir valves. Avoid use in patients with creatinine clearance of less than 30 ml per minute who are taking drug for PE or DVT treatment or recurrence of prophylaxis or prophylaxis of DVT after hip or knee replacement surgery. Avoid use in patients with moderate or severe hepatic impairment and in those with hepatic disease associated with coagulopathy. Avoid use in patients receiving drugs that are concurrent PGP and strong CYP3A4 inhibitors or inducers. For my side and adverse effects, in the CNS, there may be syncope, fatigue, dizziness, anxiety, and depression. In the EENT, there may be oropharyngeal pain and sinusitis. For the GI, we have abdominal pain, dyspepsia, and GI hemorrhage. For the GU, there may be UTI. For the hematologic, there may be bleeding events including hemorrhage. For the musculoskeletal, there may be extremity pain, muscle spasm, back pain, and osteoarthritis. For the skin, they may be wound secretion, pruritus, and blisters. The following are nursing responsibilities. Do not remove an epidural catheter earlier than 18 hours after last administration of drug, and don't give next dose until 6 hours after catheter removal unless traumatic puncture occurred. If puncture has occurred, wait 24 hours before giving next dose. Monitor patient carefully for bleeding, which can occur at any site during therapy. For client teaching, instruct patient to take drug only as directed and not to discontinue drug without consulting prescriber. Tell patient on once daily dosing that if a dose is missed, take dose as soon as the patient remembers and to resume normal regimen the following day. Advise patient to watch for bleeding risks, especially if patient had a spinal catheter or is currently taking drugs or supplements that increase bleeding risk. If a female patient, instruct to consult prescriber if she is pregnant, plans to become pregnant, or intends to breastfeed. Caution patient to report changes in medication or herbal supplements or unusual bleeding or bruising. Advise patient who can't swallow the tablet whole to crush tablet and combine with a small amount of applesauce followed by food. Instruct patient with an NG or gastric feeding tube to crush the tablet and mix it with 50 ml of water before administering via the tube and to follow administration of 15 or 20 mg tablet with an enteral feeding. Instruct patient to inform all healthcare providers that patient is taking Rivaroxaban before any invasive procedure is scheduled. That should give you enough information about us.
Thank you for watching this video. Goodbye!